sure some others will jump in. Dr. Torraca has been kind enough to host our forum today, which is great. She's done amazing things with the piezo wave. We can't decide whether it's been about 3 years, maybe 4.
Yeah.
And she has too many letters behind her name to introduce her with all those letters. But she has been a super help to me, and is currently also helping with all of the piezo wave labs at the Northeast seminar courses. So we've had a lot of experience working together. It's been great fun. But she's here to answer your questions, give you information from a vet's or a PT standpoint. So does anybody have any specific questions or things that they would like to talk about tonight?
I would like maybe some clarification on maybe using it for neurologic issues or avoiding it around neurologic issues.
Sure. So, definitely, I mean, I do use it a great deal on neurological issues. Certainly being careful if there is a laminectomy, hemilaminectomy, a ventral slot, staying away from the spinal cord region. But, definitely treating above and below as well as the sides of the area. Precautions. What I have found, and Cindy and I during a lunch and learn a few months ago, when we were talking to people about using the unit, and the majority of people are setting the unit too high, right, Cindy? Like I would say just too much intensity. So, the goal with this is not to get to the point where the patient is feeling the treatment, if you will. And I think from previous shockwave units and just this thought process is, and when I went into it and purchased the first unit, I was thinking that also. And since then, my settings are so much lower. So my, and so like with those neuro issues, I mean, I have been utilizing photobiomodulation with shockwave with my DM cases. And I'm finding with high doses of photobiomodulation, I would get almost an improvement in the dog's function. And a lot of times this was from axonal growth and increased blood supply. But then those dogs that sort of plateaued, then utilizing the shockwave over the thoracic area, lumbar area. Most of the time, these dogs have, osteoarthritis of their hips as well, probably stifles, elbows. So certainly treating the whole dog. I've been very successful with plexus injuries. So up here in the Northeast, we're starting to see a lot of the dogs jumping out of cars in the brachial plexus lesions, and again, using it sometimes in conjunction with laser. Most of the time, honestly, we have, I think, 4 class 4 lasers in the clinic. 75, maybe more % of the time, my go-to modality will be the shockwave. Just because I see quicker results, faster results with some of the, like the spinal, your IVDD. Again, maybe not if we know that the affected areas, let's say T13L1, and they're still painful, the palpation, and even lying, either the round head or the linear head on them is painful, I'm still going to look at the above and below. So work with that, and then any kind of other issues, if that makes sense. And then coming back to the affected area.
So are you talking about kind of aiming towards the spinal cord above and below, or just the musculature?
So most of the time the musculature, but also thinking about those facet joints. So, thinking about, again, T13L1, we can get a lot of facet joint changes at T10, T11, especially if the dog is dysplastic, and low level shockwave works great and penetrates deep enough to, I think, make an impact on the facet joints. Most of the time I'm following it up with active range of motion, joint mobilization, and seeing a nice difference.
Okay, thank you.
Yeah,
So-
you're welcome.
So from the literature point of view, I was just reading a human paper where they're using low energy, which they even went into the fact that it was low energy, shockwave on spinal cord injury patients, not on the spinal cord, I'm not going to say that, but they're using it on their peripheral nerves to help them keep moving and not get that total dead nerve flow and completely immobile. And they're having good results from it. And it's a 2022 paper.
Interesting.
Can you send
So
that?
I thought that was interesting. Yeah, I thought that
Yeah.
was really interesting, for sure.
If we're going to be using a shockwave over peripheral nerves, I've heard now twice, basically we're not using it over the cord itself. Why is that?
That's literature again. That's the high energy shockwave years ago when we came from lithotripsy, showed some demyelinization, very slight, but at 0.6 millijoules per millimeter squared, meaning that it became a contraindication from the International Medical Society. Is it really a contraindication? That's a call that you all have to make as veterinarians. But from the company, that's why we say to be aware of open spinal cord areas.
Yeah. And definitely like the peripheral nerves. I mean, some of our sporting dogs and that I'll see with some peripheral nerve neuropathies or, I'm over the area of the peripheral nerve, and again, using low energy. So I hardly ever go above 1.0 anymore. So I just had a giant schnauzer in that had a partial carpal arthrodesis probably 4 years ago. And he's just such a stoic beast. He's lovely, but and I had when I originally got the shockwave, I was using it much higher. And I think when he walked in, he looked at the unit and did I cause some discomfort previously? And most likely yes, because his owner was in and said, wow, like, he's a big guy, he's stoic, why are you using this at such a low setting? I said, because it's so impactful. And we have a dynamic gait analysis, and I gated him prior to treatment and then after treatment, and just looking at the improvement and the looking at his range of motion and the weight bearing. So it's always nice to see.
How do you choose frequency to use?
So the frequency, Cindy and I joke about this. The frequency is not, I think it's more of a personal thing. In my head, I have it that older dogs, I'm going to use a lower frequency, but that's nothing more than in my head. I probably also turn up the frequency higher if I've been over caffeinated. So, but I also, the audible, sound to me, like, I think as corny as it sounds, if I'm relaxing more, with a dog on the floor, and I'll tend to use a lower frequency, but it really is dependent upon you and, your comfort, and honestly, sometimes time, so certainly the higher the frequency, the faster the treatment.
So at these lower powers, do you have a certain amount of shocks that you like to give total?
So good question. Total amount of shocks total. It really depends upon the size of the dog. Let's take, for example, a German Shepherd. And if I was treating that German Shepherd for bilateral hip dysplasia, and whenever I approach a joint to start with, I like to think about circling the joint. So I always find that just from the students also, we kind of forget the medial aspect. So I try to hone in on starting medially, moving cranial, laterally, and then caudal, and probably 2,000 to 3,000 shocks per hip. And then I'll also come up to the lumbar spine and treat that area as well. And depending upon the size of the dog, anywhere from 2,000 to 4,000. So again, just depending upon, the size. Our little like Chihuahuas, our luxating patella guys, I mean, they're maybe receiving, I may hold on the medial stifle, maybe 100 to 200 shocks, and then treat the rest of the area. So maybe a grand total of 500 to 700. So definitely a little bit less. I find that the dogs are relaxing. I'm getting the changes that I need with that.
Yeah, I don't think we don't know the exact point that we turn on the process of mechanical transduction. From feeling soft tissue and trigger points and range of motion, I always say it's somewhere between 300 and 500 pulses on the specific tissue will turn on mechanical transduction, but it's an estimate. We know it doesn't take a lot, and we know that more is not necessarily better.
Or especially like stifle, cruciate. And again, like I'll start on the medial joint line and work myself around, and I finish up at the caudal stifle, and I'm looking, are the hamstrings starting to relax? So am I getting a relaxation there? Am I getting the soft tissue? Everything is kind of settling in, because of course I'm always feeling the dog, what, how are they responding to things? And sometimes, as Cindy said, I mean, less is more. I mean, you've hit your, you've gotten what you've accomplished, and then you're moving on with the multimodal approach there.
I think we also have to keep in mind in dosing is everybody has a different rate of movement, and whether they want to move a lot or they just move a tiny bit. And the therapeutic pulses are the ones that are actually entering the damaged tissue, is the way I try to think about it in my head. So when I'm personally treating a stifle, especially if there's a ton of hair and it's a huge dog and they're the least bit difficult to feel the joint line because there's so much there, like a big Bernese Mountain Dog.
Yeah.
I may actually use more pulses, but my therapeutic pulses are probably less than, because I'm still trying to get the positioning where I want it. So, I think we have to kind of understand in our dosing where we're putting the energy. And that's, some people can put the energy in from one spot and do get good results. And then, as they do more and more work with the machine, I think they get more and more what we call a dynamic method about moving around more and finding different areas that are reactive.
No, absolutely. And we have the science behind it, but then it almost becomes an art. So, what works well for you? And for example, iliopsoas injuries, or just treating the iliopsoas that is restricted secondary to a conservative cruciate management, or a TPLO or TTA or anything like that. Looking at that muscle and then working through and incorporating the lumbar component and making sure, you're getting as much. And if I have a dog that has been non-weight bearing for a while, and especially, you look at the pandemic and dogs that had to wait a while for surgery, but then, looking at the rectus femoris and the rest of the quad, so working down, and it may not be every time for the treatment, but just on that specific day. So if there's restrictions in the soft tissue and you you definitely want to take a look at that and keep an eye on that as well.
It sounds like I need to turn my intensity down just a touch. I'm
And
usually
Danielle,
running
that's like,
pretty high.
yeah, and that's, so I always joke, and like one of my vet techs has patella tendonitis, and he's the only guy in the clinic too, so we give him a hard time. But I said, go ahead, like turn it up, and as feel it, what it feels like over the patella, a fairly bony area. And he's like, oh gosh, you're right, and it's definitely intense. So he was able to experience that, and then bring it down a bit and experiment with himself on his quad versus the patella tendon. And but most people do. And I think, like I said, when I got the unit, I thought, okay, this needs to be, let me see how much the dog can handle, how much. And that's not it. And
Right.
looking at the dosages, and I look back on some of the animals that I saw 3 years ago when I started with it, and now, and just much different approach. And I'm not getting that my dog was so sore after the visit, and they're, again, kind of facilitating that whole multimodal approach, reducing that pain and inflammation and getting them moving, not, having a day where they were hurting. And, really, I tell my clients that if the dog is tired or a little bit out of it for 4 to 6 hours after the visit, that's to be expected. But if it goes beyond that, then we overdid it. And that could definitely be with shockwave. It could be with Therex, or, anything else, range of motion, stretching, that sort of stuff.
Yeah, for sure.
Yeah.
Interesting.
Yeah, no, it is interesting. And, like, try it on yourself, if you have an area, especially like, over like where people commonly get tennis elbow. And I know when we do it in the labs and everyone is, I want people to kind of put themselves through the roof, so
Yeah.
you feel, especially like you think about a dog on the medial joint line, or like I have a dog with a partially torn calcaneal tendon. It's not a surgical candidate. And that's even though it's so rich in blood supply, it's a very sensitive area. So, thinking about that.
Yeah, I was fortunate that when I had it on kind of the trial period that Cindy allowed, I had a couple of, my brother lives nearby and he has teenage boys, and a bunch of Marines, and they have friends that have damage. So I was like, all right, then carry him over here.
Yeah.
Because it was nice to get like a person to
Yeah.
say, oh my gosh, my shoulder felt so much better.
Oh,
So I was really impressed, because none of the people, well, my sister has a frozen shoulder issue, so she found it painful, that whole intensity issue. But after, a couple of treatments, she had more mobility than she had had in 6 months.
Yes, definitely.
So, yeah, that was a selling point for me, having the people kind of give you the feedback.
Yes, no, definitely. My husband probably 2 years ago was having some cervical issues, some radiculopathy, and he went to the neurologist, who's a personal friend of ours, and he referred him to a chiropractor that had the same shockwave. And my husband was telling me about it, and I said, really? Like, I have that. And so the neurologist wound up bringing his dog in, and he was so like fascinated by how this was working on animals, and about just like everything. Our treatment was like, or the dog's treatment, we were just like focusing on all this stuff. And he's like, wow, this is really cool. He's like, I always thought, the people, my patients, were supposed to like be biting on a towel while they're having this done. I'm like, no. So it was, and it was cool to get like his human perspective, because of course, like the difference, especially between cervical and, talking about neurological issues. And it was pretty neat. And So yeah, he's like, oh, I'm definitely for my human patients, I'm going to refer this more. I'm going to tell every dog owner. So it's so
Nice.
funny. And his dog was non-weight bearing from a conservative cruciate. And after one visit, the dog was like running, playing. He's like, wow, this is
Dang.
great. So I
Wow.
was like, see, you don't always have to cut. Like, so it was pretty cool to, kind of play around with that and listen to that too. So
I did a couple of dogs for one of the vets in town to do some of my cases for the CCRP or the course thing. And the one dog had the worst medial shoulders, and she was a senior. So there was nothing we could do with the shoulders at this point, but she walked with her head just scrunched down from her cervical pain. And so I treated her neck, both trying to do like from the top to get to the cervical area with the 30 pad very deep, and then from the sides to do the muscles. And the next morning she sent me a video and the dog's head was like poked up. I was like, okay.
Nice.
and that's so like, I think so often too, like we have those older guys that come in, they have, bilateral elbow dysplasia, hip dysplasia. And yeah, like it can definitely make a difference, but I may start treating like the cervical area, the thoracic area. So they start to relax there and then maybe work on those elbows so we can get some more weight bearing there. And we've got that whole area relaxed, like, all those wonderful strap muscles and the omo transversarius and all of that. And that really makes a difference. And, I have to explain to owners, like, I know your dog has elbow and hip dysplasia, but we're going to start here because they've been compensating for so long. Probably like Danielle, like your sister with a frozen shoulder. I'm sure her cervical area was pretty involved from like all the
Right.
stuff like that. So, sometimes too, it's looking like, okay, let me work on this. And then I'm going to, then in my treatment plan, I'm going to plan on addressing the other, area. So, but definitely, making them like the DM cases, like we see a lot of DM dogs, and as they're in, maybe carts or they're starting to get towards the end where they're dragging more and treating that cervical area, treating those shoulders, and just quality of life, making them feel a lot better.
Yeah, I think that's a learning curve for us as students, is picking what battle to choose, and especially trying to find the most strongest, or it's not even the primary source of pain, it's the worst source of pain. And that's where I'm trying to go to first, but it's not easy to find as we learn.
Right. And I always look at, like in my notes, when I'm evaluating an animal, looking, today I look at primary, secondary, and tertiary areas that I want to focus on. And that may, it often does change on a regular basis. So that's, important to look at, with your treatments, and, too, with, as we pass things along to our technicians, and, my techs know, okay, this is going to change. And, just based on, we have a dog in here right now that's 14, most likely has a brain tumor or something, a weird form of ataxia, and just starting with nosebleeds. And we had a very frank discussion with the owner. And the owner said, I have no expectations that we're going to be curing anything. I just want him to be more comfortable, so it's quality of life. And shockwave is one of the things that makes him feel much better. And he comes right now once a week until, who knows, maybe next week will be his last, but it's just about that quality of life and looking at that.
It sounds like you divide your DM dogs and kind of do different anatomical areas on different visits, because we kind of do most of the dog when it shows up. Is that incorrect?
So it'll depend. Definitely if they're, just starting targeting the thoracic and the lumbar area, and, that may change. I think as the dog they're starting to lose more and more motor function, and I, again, clinically just have not then seen a lot of results from either photobiomodulation or shock waves. So then we'll move up, more cranially, unless they're in pain from hip dysplasia or, something else going on.
Whether you treat the whole dog or different spots, I don't really think we could say there's a right or wrong, because that's part of the art we deal with. But I have seen dogs where we've treated too much and they just go home exhausted and like just mushy, like they don't have any, if you take away every bit of compensation, they're not functional enough. So that's kind of where I kind of try to stop and say, does he need this tension to function at the moment?
Right. Yeah. Good point.
Yeah, like definitely, like you look at cases of wobblers, whether they've had a surgical intervention or not. And I mean, a lot of that muscle tightness, if you will, or hypomobility is serving to protect the spine. So yeah, definitely looking at that. We don't want to turn them into mush because those tight muscles are keeping the cervical spine, functioning, if you will. The same thing sort of, in people. Sometimes a muscle spasm warns us, not to do something more stupid, maybe.
We've been real pleased with it so far.
That's
Sometimes I worry about implants. Like, is that going to cause a problem? I have gone over implants and tried to aim around, and I never have seen an animal react like it was problematic, but I don't want to loosen anything that I shouldn't loosen.
no,
So you're not going to move an implant.
I don't want to vibrate any screws a little bit.
No, the issue with the implants is that shock wave and the pressure waves will reflect off them. So you're not going to, if you hit the implant before you reach the tissue you're trying to hit, it won't be therapeutic.
Gotcha. Just wasted.
So that's why we try to drive around them for sure.
My intention is to drive around them. Like you said, a big, heavy muscle dog, you just kind of hope for the best.
But we've had total hip replacements and our TPLOs and TTAs, and most of the time just staying away from it. And but yeah, you won't loosen things or
Have you used shockwave for fibrotic myopathy?
Yes, very good question. So I'm treating a police dog right now. I think he's in, and he has fibrotic myopathy. He's such a high drive dog. He started his initial presentation, we thought was a stifle injury, and he wound up having a lateral meniscal tear and a lateral femoral condylar fracture, which we don't know where that came from. But as he was, as we're watching him, and it became apparent that also fibrotic myopathy was there. And we actually returned him to work. I mean, part because he's a psycho and needs to do something. And, he lives at home with his handler, but using it on the affected muscle. So with him working on the adductors, followed by pretty intense stretching. And we see him once a week, just the schedule. Ideally, we'd love to see him twice a week, but just with his department, it's once a week. And the owner continues with the stretching. So I hate those cases of fibrotic myopathy because they just are so tough, especially in those shepherds with the angulation in the rear. But so he's back to work. I laugh, like he could go flying after a bad guy. It may not look that pretty, but he's moving really fast.
He's gonna get him.
Are you,
And it's like mentally, he's like back, like where he needs to be. So it's
are
great.
you sticking with your lower power settings or
Yep.
are you? going-
Yeah, especially like, so, I mean, I think about him and intact male and, where we are. Yeah, so I probably with him, I would say between 1 and 2 with him. We've definitely started off pretty low, just again, nervous shepherd, that sort of thing. But there are days too where 1 is way too high, so we drop it, back down to 0.5, 0.6. It'll differ.
Easy. I didn't know
Yeah.
it went down below 1. Because
Yeah. Yep.
I've been doing all mine around like 8 or 9, unless
Yeah.
the dog reacts and then I back it down.
If you hold the minus button down for 5 seconds on your unit, it goes to 0.0.
Wow.
And down in that low range, there does seem to be much more specificity in when the dogs kind of feel it. It's weird, but play with it.
Yeah, for sure.
Well, this brings up a scientific topic of creating tissue inflammation like we classically wanted to do versus turning on mechanical transduction at the cellular level and not worrying. We now, when we turn on mechanical transduction at the cellular level, we're moving tissue. That's all we're doing. So we don't have to have pain and inflammation. We don't have to worry about NSAIDs. We don't have to worry about those type of classic things that 5-10 years ago were a question mark with Shockwave.
Any other questions or?
So I've also heard that you have a protocol for laryngeal paralysis.
Yes. So more of like, I should like write something about it. So that was one of my experimental thinking about people and all of that with looking at laryngeal paralysis and how many are, truly LARPA, are they associated with your geriatric onset of, paralysis, older dogs that do have this polyneuropathy going on, this weakness. So I always explain it that with laryngeal paralysis, so the dog has their head way more forward. And if those of you that are listening, just stick your head forward and you hold it there for a moment, you could feel the tension in your suboccipital space. Also, the hyoid starts to rise. And when you're in that position, it's fairly hard to swallow. So I think about these dogs in this position and they're having trouble breathing and the humidity is making it worse. So I'll start by treating the suboccipital space, going in there, coming along the side. So not over the trachea per se, but getting all of these muscles to relax in here. And working on having the dog almost do their own chin tucks, I put peanut butter on their nose so they're starting to loosen that up and do a little bit of mobilization for the hyoid. And I've had great success with that. A lot of times with these guys, like the owners are using the SCC loop at home to reduce the inflammation around the laryngeal area. But again, changing that posture, so to get them out of it and, treating, again, suboccipital space and then coming onto the lateral side and treating very light. So like 0.5, you have to be careful, suboccipital space, increased blood flow, also, of course, near the laryngeal area. But I've had great success. Like it's so humid up here right now, and all of the dogs that kind of have this are, so much worse right now. So kind of had a few of them already today. Any other questions?
Can I ask a question about the use of it in wound management? And I'm talking about major wounds that have an impact on mobility and motion in an animal, like near a joint or.
One of my technicians sent me her own dog, German Shepherd, like had a puncture wound, and she said, oh, I'm just going to shockwave this and, put saran wrap over it and shockwaved it and was looking at the whole healing. So we wound up having wounds from its help 'em up harness, not fitting properly, all of that. We put transdermal covers on and treated. So you can definitely do that. I don't have a ton of experience with it. Maybe Cindy has more like to talk about wounds, but
I saw pictures of a cat that had a wound all the way through its paw, and they treated it with the shockwave, and it healed. It healed for sure. So I've seen some pretty amazing things. Personally, I don't touch the wounds if they're doing well on their own. That's just the science in me, if biology is doing its thing. But as soon as they get stagnant or non-healing, for sure.
I mean, we've normally turned towards photobiomodulation for the wounds. But yeah, so it's definitely something that we're looking at. We just don't see, because we're in outpatient, don't see as many wounds as probably inpatient.
Have you tried it on wounds yourself, Dr. Julie?
Yes, it's my own personal horse who's had a horrific degloving injury in the hind limb. And I did an initial treatment and could have swore that granulation tissue came about much quicker than I thought it would, which was good. And then I got a little overzealous and treated it again, and then the tissue was bad the next time. So I backed off. But I'm starting to get a lot of proud flesh. I don't know how many people work with horses, but proud flesh is kind of insidious in the distal extremity injuries. And I've been researching the shockwave use, and they're thinking that it might help slow down the development of proud flesh.
Mm-hmm.
So as the wound goes along and we start to get a little less exudate, I'm going to revisit it, probably at a lower intensity.
Low, yeah, I would. If you keep the intensity low, I think you should get good results.
Anything else?
Janet, you're doing more and more with your shockwave now that you
yeah, we seem to be seeing a lot of shoulders.
Okay.
And the interesting part to me is that some of those have gone for musculoskeletal ultrasound pre and post, and it's nice to see that they can actually show that there is healing.
Yes.
The dogs don't seem to always necessarily show symptomatically that they're healing as early as the ultrasound seems to be showing it. So I'm on the right track, I guess.
That's good news. I'd love to see any cases with ultrasound data. I love my ultrasound data. So, and Dr. Gaston, you just got yours a couple months, 6 months ago or so. Are you guys doing well with it still?
Oh yeah. It's terrific. I just wish I could treat my clients in addition to my patients.
I know.
I have so many clients that would benefit from this, and we've tried to have them call the company and find out if anybody, a human practitioner has one of these machines. And it's sad that it's not more available and more widely known, because it's an incredible tool.
It's growing. It's just been hard to get the PT side to accept that it doesn't have to be that huge amount of energy.
Yeah, my youngest daughter is trying to get into PT school now, and she was talking to her chiropractor down in Greenville, South Carolina. He's like, "What's the name of that machine your dad's using? Because I got to get one." And so anyway, so I think that it will get more widely used. I just don't think people understand what an amazing tool it is. So it has great impact on so many of my patients and my staff and me and my family.
Absolutely. I know we have 2 units in our office, and my husband will often say, well, just, lug one home. I'm like, oh, they need it, right now. So
there's a message from Waves. We have a
Yeah.
small dog. What do we do with that? We have a small dog with carpal and digital flexor contractures from an 8-week splinting for ulnar fractures. What do you suggest for settings?
So good question. So definitely, because that's so superficial, we want to keep the settings pretty low. For frequency, I would choose anywhere between 3 and 6. I mean, just pick your pleasure, but definitely start low, like 0.2 to 0.5. 0.5 may be even too much. Again, there's not a lot of soft tissue there, but you're working on that area using the round head, probably more of a pinpointed head there. So
Yeah. If it's a small dog, one thing I do say when you're working in that carpal area that has very little musculature around, don't be afraid to use the zero pad. Especially maybe for the first couple of treatments until they get used to it. Because when you start hitting bone hard, it can be super painful, and there's not much in between the bone and the tissue, the bone and the skin. So that's one thing. People sometimes are hesitant to pull out the zero pad, and I'm like, don't be hesitant. You still have the second half of your focal zone, and you still have the center of your focal zone. So that's something to keep in mind.
But it works, well, like we see a lot of carpal injuries and distal fractures. A 9-year-old Staffordshire Terrier that was getting ready for Westminster, and 6 weeks prior, his son bit him and fractured his ulna, distal ulna. And the owner was like, this is his shot at, doing really well. I mean, he's done like everything that an AM staff could do, but she wanted one last hurrah. And we worked, he had used the home laser, and we were shockwaving him twice a week, and then started getting him back an underwater treadmill. He wound up winning the breed, taking a group placement, was perfect, so the owner didn't follow up with radiographs. She was just like, okay, he's done, that sort of thing. But, to go from I won't say a significant lameness, because they're kind of blockheads, so he definitely had, measurable lameness, on our dynamic gait analysis and visually as well. So it was a huge impact. And we had the wound over, which I guess I didn't really think about this too, because we had the bite wound. So we were covering it, shock waving it, and that wound healed up beautifully as well. So
you mentioned that you were treating twice a week. How do you decide how frequently you?
I think it really depends upon what's going on with the dog. Most of our post-ops will try to get them in twice a week. That doesn't always work. I mean, a lot of times it's dictated by the owners. But like an FHO, we really try to get them in twice a week. Our DM cases are more chronic, like OA, they're coming in once a week, and then we may taper down. So.
Okay, so you started saying the more acute the injury, the more frequently.
Yeah, or unless it's like a dog, like the show dog, if there's something like pressing, we'll see them more. So.
Can you do it too often? If you do 3 times a week, I mean, at what level is it excess?
Even if a dog comes in 3, 4, 5 times a week, we'll only shockwave them twice a week. I find that that's enough, especially with our soft tissue. So, if we're working on other things, strengthening and that sort of stuff, I'm sure, I don't know, Cindy, if you have.
So in the human world, when they can understand what's going on, they do use it more often. But in some instances, in the veterinary world, when the animals can't talk to us, my reason for sticking to twice a week is that we have an analgesic phase of 3 days. And I want that to be done with before I retreat. So I'm back to baseline biologic feeling and not just this pain relief that I don't really know, what's going on for the healing in the biology. So that's why we recommend it in that way, shape, or form.
I just, I ask these questions just because it seems like there's so much uncertainty with this thing. And so much is flying by the seat of our pants, but I guess that's just the nature of it right now.
Hopefully that will get better.
I know we have all of the science, and it's trying to figure out what's going to work, and, and getting more consistent, so if more people are treating with an intensity of 7, 8, or 9, there's the chance of, more soreness, that sort of stuff. Like a lower dosage where, we're not seeing that. So yeah, I think there's a lot of variability right now.
Tremendous amount of variability. And, it's because it's so pet dependent. Like my own corgi, we've been working on his back because he's ancient and crippled. But he's got trigger points that come back at day 2 every time that I shockwave him. So working with the vet that's in town, she's finally said, let's shockwave him in the morning before you bring him in, because I am really suspicious that he has a rib head out, but I can't adjust his ribs because he's so painful. So, normally would I shockwave him before he got, went in for acupuncture? Normally I wouldn't, but, because of this case and the purpose, like it's all about having a purpose for what you're doing. If there's a purpose to do it more often, or a purpose to try something different, I believe in it.
Mm-hmm.
Okay.
Just keep track of it. And if you hit gold and it's an amazing thing that happens, let us know so we can share it with everybody.
Yeah, well, we're working on it. We're, we've been setting it way too high, trying to work towards tolerance, that kind of stuff. And, that maybe that hasn't been the best thing. So anyway, learning as we go.
We all are. That's a constant discussion we have to have in these courses we teach, because things change over time. We learn more.
Definitely.
We have to be adaptable in this world. So
Gotta go with the flow.
Yep, got to try things, and I appreciate, people sharing what they've had, good, bad, indifferent, because that's how we're all going to learn. They have a question at Waves about when the pads need to be replaced. So they should never need to be replaced as long as there's not physical tears or rips in them. If they're discolored from sunlight and gel, that should not be a problem. Okay. I've seen them turn at a horse barn I was at recently, a horse that it turned like brown. And I was like, that is disgusting, but it still works well. Don't let them be chewed up. That's the biggest thing. So we're about time, and I just want to say thank you to Dr. Torraca for her time. I always appreciate it.
Yeah, absolutely.
I appreciate everybody who made time to come talk, and we will be putting these recordings on the landing page, so when you can't make it, you can listen to them in the future. Okay?
Awesome. Thank you so much, guys.
Thank you, everyone. Have a great night.
Thank you very much. Take care.
Bye-bye.
Bye.